This lecture will go over aneurysms of central and peripheral arteries as well as aortic dissection. An aneurysm is a permanent localized dilation of an artery, which enlarges the artery to at least 2 times its normal diameter. In true aneurysms, the arterial wall is weakened by congenital or acquired problems. False aneurysms occur as a result of vessel injury or trauma to all layers of the arterial wall. Dissecting aneurysms differ from aneurysms in that they are formed when blood accumulates in the wall of the artery. Aneurysms tend to occur at specific anatomic sites, most commonly in the abdominal aorta. An aneurysm forms when the middle layer of the artery is weakened, producing a stretching effect in the inner layer and outer layers of the artery. As the artery widens, tension in the wall increases and further widening occurs, thus enlarging the aneurysm and increasing the risk for arterial rupture. Elevated blood pressure can also increase the rate of aneurysmal enlargement and risk for early rupture. When dissecting aneurysms occur, the aneurysm enlarges, blood is lost, and blood flow to organs is diminished. Abdominal aortic aneurysms, or AAAs, account for most aneurysms, are commonly asymptomatic, and frequently rupture. Thoracic aortic aneurysms are not quite as common. They are located in the descending, ascending, and transverse sections of the aorta. They can also occur in the aortic arch and are very difficult to manage surgically. Aneurysms can cause symptoms by exerting pressure on surrounding structures or by rupturing. Rupture is the most frequent complication and is life-threatening because abrupt and massive hemorrhagic shock results. Atherosclerosis is the most common cause of aneurysms, with hypertension, hyperlipidemia, and cigarette smoke being contributing factors. Most patients with abdominal or thoracic aneurysms are asymptomatic when their aneurysms are first discovered by routine examination or during an imaging study performed for another reason. However, few patients do have symptoms that bring them to their primary healthcare provider or the emergency department. Assess patients with a known or suspected abdominal aortic aneurysm, or AAA, for abdominal, flank, or back pain. Pain is usually described as steady with a gnawing quality, unaffected by movement, and lasting for hours or days. A pulsation in the upper abdomen slightly to the left of the midline between the xiphoid process and the umbilicus may be present. A detectable aneurysm is at least 5 centimeters in diameter. Auscultate for a bruit over the mass, but avoid palpating the mass because it may be tender and there is risk for rupture. If expansion and impending rupture of a AAA is suspected, assess for severe pain of a sudden onset in the back or lower abdomen, which may radiate to the groin, buttocks, or legs. Patients with a rupturing AAA are critically ill and are at risk for hypovolemic shock caused by hemorrhage. Signs and symptoms include hypotension, and that was hypotension, diaphoresis, decreased level of consciousness, oliguria or scant urine output, loss of pulses distal to the rupture, and dysrhythmias. Retroperitoneal hemorrhage is manifested by hematomas in the flanks. Rupture into the abdominal cavity causes abdominal distension. When a thoracic aortic aneurysm is suspected, assess for back pain and manifestations of compression of the aneurysm on adjacent structures. Signs include shortness of breath, hoarseness, and difficulty swallowing. TAAs are not often detected by physical assessment, but occasionally a mass may be visible above the suprasternal notch. Assess the patient with suspected rupture of a thoracic aneurysm for a sudden and excruciating back or chest pain. Hypovolemic shock can also occur with TAAs. CT with contrast is the standard tool for assessing the size and location of an abdominal or thoracic aneurysm. The desired outcome of non-surgical management is to monitor the growth of the aneurysm and maintain BP at a normal level to decrease the risk of rupture. For those with small or asymptomatic aneurysms, frequent ultrasound or CT scans are necessary to monitor the growth of the aneurysm. Emphasize the importance of following through with scheduled tests to monitor the growth. Also explain the signs and symptoms of aneurysm that need to be reported promptly. Surgical management for aneurysm may be elective or an emergency procedure. For patients with a rupturing abdominal aortic or thoracic aneurysm, emergency surgery is performed. The most common surgical procedure for AAA has traditionally been a resection or repair. However, the mortality rate for elective resection is high and markedly increases for emergency surgery. Endovascular stent grafts have improved mortality rates and have shortened the hospital stay for select patients who need AAA repair. The repair of AAAs with endovascular stent grafts is the procedure of choice for almost all patients on an elective or emergent basis. The endovascular stent grafts are inserted through a skin incision into the femoral artery by way of a catheter-based system. The catheter is advanced to a level above the aneurysm away from the renal arteries. The graft is released from the catheter and the stent graft is placed with a series of hooks. Complications of stent repair include conversion to open surgical repair, bleeding, aneurysm rupture, peripheral embolization, misplacement of the stent graft, and endoleak. When discharged home, the patient must follow instructions regarding activity level and incisional care. Because stair climbing may be restricted initially, he or she may need a bedside commode if a bathroom is inaccessible. Teach the patient who has undergone surgical repair about activity restrictions, wound care, and pain management. Patients may not perform activities that involve lifting heavy objects, usually more than 15 to 20 pounds, for 6 to 12 weeks after surgery. Advise them to use caution for activities that include pulling, pushing, or straining. Most patients are restricted from driving a car for several weeks after discharge. Teach the patient receiving treatment for hypertension about the importance of continuing to take prescribed drugs. Instruct them about the signs and symptoms that must be reported promptly to the healthcare provider, which include abdominal fullness or pain or back pain, chest or back pain, shortness of breath, difficulty swallowing, or hoarseness. Femoral and popliteal aneurysms are not common. To detect a popliteal aneurysm, assess for a pulsating mass in the popliteal space. To detect a femoral aneurysm, observe for a pulsatile mass over the femoral artery. To prevent its rupture, do not palpate the mass. Evaluate both extremities because more than one femoral or popliteal aneurysm may be present. The patient may have symptoms of limb ischemia, including diminished or absent pulses, cool to cold skin, and pain. Alterations in comfort may be present if an adjunct nerve is compressed. To treat a femoral aneurysm, the surgeon removes the aneurysm and restores circulation using a graft. Most surgeons prefer a bypass rather than to resect a popliteal aneurysm. After surgery, monitor for lower limb ischemia. Palpate pulses below the graft to assess for graft patency. Often Doppler ultrasound is necessary to assess blood flow when pulses are not palpable. Report sudden development of pain or discoloration of the extremity immediately to the surgeon because it may indicate graft occlusion. Aortic dissection is not common but is a life-threatening problem. Aortic dissection is thought to be caused by a sudden tear in the aortic intima, allowing blood to enter the aortic wall. Degeneration of the aortic media may be the primary cause for this condition, with hypertension being an important contributing factor. This condition is highly lethal and represents an emergency situation. Although the ascending aorta and descending thoracic aorta are the most common sites, dissections can also occur in the abdominal aorta and other arteries. The most common symptom is pain. It is described as sharp, tearing, ripping, and stabbing, and tends to move from its point of origin. Depending on the site of dissection, the patient may feel pain in the anterior chest, back, neck, throat, jaw, or teeth at a level of 10 on a 0 to 10 pain intensity scale. Diaphoresis, nausea, vomiting, faintness, and apprehension are also common. BP is usually elevated unless complications such as cardiac tamponade or rupture have occurred. In these cases, the patient becomes rapidly hypotensive. A decrease or absence of peripheral pulses is common, as is aortic regurgitation, which is characterized by a musical murmur best heard along the right sternal border. Neurologic deficits such as altered level of consciousness, paraparesis, and strokes also can occur. If the patient is medically stable, a thoracic MRI is the test of choice to confirm diagnosis. However, the patient is often too unstable to be transported, and a transesophageal echocardiography may be performed at the bedside. The expected outcome for emergency care for a patient with an aortic dissection are increased comfort and reduction of systolic BP to 100 from 100 to 120. Make sure the patient has 2 large bore IV catheters to infuse normal saline and give medication. Insert an indwelling urinary catheter. The healthcare provider prescribes IV morphine to relieve pain and an IV beta blocker to lower heart rate and blood pressure. Subsequent treatment depends on the location of the dissection. For long-term medical treatment, the systolic BP must be maintained at or below 130 to 140. Beta blockers and calcium channel antagonists are prescribed to assist with BP maintenance once the patient is stable. Patients having surgical intervention for a proximal dissection typically require cardiopulmonary bypass. The surgeon removes the intimal tear and sutures edges of the dissected aorta. Usually a synthetic graft is used.